delighted to be able to welcome Professor Michelle Morse, instructor in medicine and the Department of Global Health and Social Medicine affiliate at Harvard University, Professor Barbara Prainsack, who is Professor for Comparative Policy Analysis at the University of Vienna and Professor of Sociology at King's, and Professor Anne Pollock, Professor of Global Health and Social Medicine, King's College London. Last but certainly not least, Dr. Carlo Caduff, Reader in Global Health and Social Medicine at King's as well. So I am, full disclosure, a soft-palmed and lily-livered arts and humanities grad. So my sense of syndrome this evening is literally suffocating. I do not want to spend too much of my time abusing my position as chair and waffling on, but by way of an introduction, perhaps I would like to briefly discuss why I think talks like this are so important. Because from my own vantage point, working in the media over the course of this pandemic, I've seen that there is just a huge gulf between the public's appetite for robust and critical interrogation of government policy and how little that need is actually being served by legacy media outlets. And particularly here in the UK, but I'm sure this is also the case in the US as well, there is this clubby culture amongst journalists who cover Westminster and Washington and top-level politics. And so there is a willingness, I think, to take the government at face value and claim somewhat ridiculously that when the government changes its mind, it's because the science has changed, not because the government's suddenly been made aware that the facts of the pandemic conflict with their own political priorities or ideological perspectives. And because of this, I think, willingness to take the government at face value, there's been a real disservice to the public. And that's not just a moral outrage that we are being failed by the media. At a time like this, the public's lives literally depend on the quality of information that's available and how informed the debate that's taking place is. And the impact of the pandemic and its mismanagement has been hardest felt by those who are already most vulnerable. Life expectancy in Britain's poorest areas has been falling. Meanwhile, in the United States, communities of colour, low-income households were both more likely to contract the virus and more likely to die from it as well. So the point of public engagement events like this is not just so academics and experts can justify their jobs to themselves. Actually, it's about giving people the tools to understand and perhaps even combat the injustices that surround them. So with that in mind, I would like to invite our panelists to kick off with a short, and I mean short, 2 minutes answer to an opening question. If you could prioritize just one thing, one policy, one goal in terms of healthcare and global health, what would it be and why? So who should I pick on first? Anne, can we start with you?
Sure. So thank you so much, Ash, for hosting us all and for convening us with these questions, and to James Bagley and others at King's College London who have kind of brought us together. Although I think I might like to cheat a little bit to answer your question by highlighting something that's not precisely medical. I think that a lot of the impacts that we've seen from COVID-19 have been due to baseline infrastructure that structures inequalities in health more broadly. So I think for me, my home state is Michigan, and hearing early on in the pandemic about situations of people whose water had been turned off because of non-payment of bills or late payment of bills or whatever it might have been, in a time when we needed to shelter in place and washing hands was never more important, just really brought home to me that the very baseline infrastructure that we assume should be there in the context of a wealthy and democratic society like the United States sometimes isn't there. And I think that for me, the big policy kind of sweep that I would make would be to make sure that the basic necessities of life, safe housing, clean water, these kinds of the basic kind of income that allows you to keep yourself fed and clothed, that those are really where I would put the priorities, rather than in high-tech medicine or, kind of treatment courses and tests that are COVID specific?
That's a great answer. Michelle, maybe if I can invite you to add to that, answer the question in whatever way you see fit.
Yeah, it is an expansive question, but I appreciate it. And I think ultimately you're right. We do need to really know what direction we're going in, what we're prioritizing. I think from my perspective, having spent the past 15 years doing global health equity work, global solidarity work, and also a lot of work around social and structural change and critiquing the field of medicine, which I'm a part of, and how we tend to only function in the biomedical model and misdiagnose and misconstrue the true causes of health inequities. I'm glad that that's shifting, but where I would love to see it shift more, and where I would, if I had it, if there were a silver bullet, the issue I would focus on is, intellectual property rights and the current global kind of both pharmaceutical and biomedical industrial complex, and the way that it systematically excludes, marginalizes, harms, and disadvantages global South countries. And in addition to that, our lack of recognition and our lack of acknowledgement of the fact that that global dynamic, that global economic system really is rooted in colonialism, and rooted in the fact that we have never been able to successfully ensure that economic rights are viable for our colleagues and comrades in the global South. And we see that with vaccine apartheid very, very clearly, right? I mean, I think the United States, as thankful as I am being, the chief medical officer of the New York City Health Department here, and as thankful as I am about how plentiful vaccine supply is for us, it comes at a cost, right? The U.S. Ordered far more vaccine than we needed. And that is directly related not only to the fact that the vaccine's not available in many countries in the global South, but even more so the intellectual property rights that govern access to manufacturing capacity and access to the vaccine in countries in the global South is again both a direct result of colonialism and not remediable by charity alone, and donations of vaccines alone is not going to get us to where we need to be. So that would be the issue that I would end with my silver bullet.
Yeah, and that's definitely a theme that I want to pick up on, which is we often talk about putting health at the heart of policy, but is that sort of a technocratic solution? And actually there are these conflicts with capital, which are really the underlying issue here. So definitely both things I want to talk about, infrastructure and intellectual property. But Carlo, if maybe you could tell us what your silver bullet thing would be. And I'm really sorry if one of these two has already named it. You then have to kind of come up with a slightly less good one.
Sure, no problem. So, very often we hear that the failure in the pandemic response happened because we were not prepared. But the failure in the pandemic response happened despite decades of pandemic planning and preparing. So when you look at the history of preparedness, you'll see governments across the world, even the WHO, invested a lot of resources and ideas into preparing for a pandemic over the past 20 years. A lot of plans were made across all kinds of different levels. So a lot of preparedness actually happened. So for me, the question is not, why were we not prepared, but why was this the wrong type of preparedness? And why did the pandemic response fail despite so much effort and so much resources invested into preparedness over the last 20 years? So one recent publication that I found very insightful is Lee Jones and Shahar Amir's account of the British pandemic response. And in this piece, they argue that something happened in terms of governance, and that there was a shift and there was an emergence of a new type of governance, which they call the regulatory state. And so we need to understand the nature of the state and how the state itself changed and how governance itself changed in order to understand why we've seen what we've seen over the past few years. So they emphasized the pandemic was neither unprecedented. Infectious diseases kill millions of people year after year. HIV/AIDS alone killed over 30 million people. So it wasn't something that was unprecedented. And there were other infectious diseases like SARS and then avian flu and etc. Nor was it unexpected. Over the past 3 decades, public health professionals and government officials have been preparing intensively for a catastrophic pandemic. So the question is, what happened? And what happened is that over the past 3 decades, government was largely replaced by governance, whereby resources, authority, and responsibility are dispersed to diverse public and private actors, while central state managers retreat to a regulatory role, using negative coordinations to steer these actors in broadly favored directions. So as a result of this process, the state has neither the capacities nor the authority to actually control the spread of an infectious disease, such as COVID-19. And you see this form of governance even at the level of the WHO, because, in a sense, the WHO preparedness plans, they're kind of outlining what other people are expected to do, what other people should be doing. But that doesn't necessarily change anything in the world, right? I mean, you can come up with very long plans outlining what other people should do. But if they're not doing that, then you haven't changed anything whatsoever. So this goes a little bit back to what Anne was saying in terms of infrastructure, and highlights a similar point.
That's definitely a point I want to come back on is, to what extent are we dealing with the end of a 40-year process of states hollowing out their own capacity to do stuff? I think it's going to be really central to this conversation. But last but certainly not least, Barbara, your silver bullet policy or goal, or maybe just the thing you really want to talk about.
Thank you, Ash. I think my silver bullet is to stop thinking about silver bullets, because what we have seen now and heard from all 3 previous speakers is how connected everything is. And one thing that COVID has really driven home is, the idea that everything is health policy. So the initiative by the WHO, Health in All Policies, might have seemed new to some, and might have seemed counterintuitive or in a way radical, but it no longer is. I think people now have experience with housing policy being health policy, employment being health policy, and people have experience all over the world, although in different configurations, of course, and with different needs and wants, what it means if you don't have the foundational infrastructures that Anne was talking about, and if you have the kind of inequities and discrimination that Michelle has talked about, and if you have to you meet your basic needs on the free market. So I think I can only echo really what Anne was saying, that if we accept that everything is health policy and that different policy fields are connected, and we have to think of also doing policy in a different way, that we don't sit on sort of resort silos where certain budgets are devoted to X and something is devoted to Y. We have to think in a more integrated manner, and we have to really think about basic infrastructures and services that include, to my mind, a universal basic income all over the world, and not only in the rich countries. For lots of people, this is a very strange thought, but for whom it is a strange thought, or to whom it is a strange thought, I would say, would you agree that we provide basic services to everyone? If not, then why is money so different? And I think we definitely also need a strategy for long COVID, again, all over the world, but of course in different configurations and addressing different situations. And I think one thing we should stop doing, and this is also connected to everything that was said before, is that we have really seen that this nudging stuff does not solve anything. So nudging doesn't get you PPT, nudging doesn't get you basic infrastructures. So the idea that was very hip among policymakers and also scholars, that we have to tackle the demand side because we have tried to work on the supply side for a long time and it hasn't worked, right? Because healthcare is still getting more expensive. I mean, it's really about the supply side. And I think if the supply side is right, then and if people don't need to worry, they don't have to have existential worries, they don't need to worry about their basic needs, then the demand side is going to fall into place.
I think that's a really good place to jump into my next question, because I was hearing what you were saying about nudges not working. And I thought about how, particularly in the UK under Boris Johnson's government in the early stages of the pandemic, they'd really vaunted the existence of what they called, the behavioural change unit. So the idea was that by implanting in the public's mind that you had to wash your hands for as long as you could sing the national anthem or something ridiculous like that, that's magically we would be protected from the virus despite not locking down when every other country on the planet seemingly was doing so, right? So there was an ideological imperative there, right? It was that, well, we are a free market conservative government. We don't like the idea of the state telling people what to do in order to protect their health. We like the state telling people what to do when it comes to, a surveillance state, but we don't like doing it for, reasons of public health. So we're going to pursue an entirely discredited model of pandemic management, right? And that was one thing which created a vulnerability in terms of the country, right? We had this government ideologically wedded to one way of doing things. And so the thing that I wanted to talk to you guys about is, well, why is it that countries with, higher rates of income inequality were more vulnerable to coronavirus, both in terms of people being more likely to get it, being more likely to die from it? What is it about unequal societies which creates this kind of structural vulnerability? Is it simply ideology, or are there other things at play too? And so whoever wants to just take that and run with it, go for it. Otherwise I'll start picking on people. Michelle, you're smiling at me, come on.
It's such a big question. I think all of us were like, where do we start with that one? It's hard to know where to start. I mean, I guess I would say, especially as a Black American woman, it so much, of course, is driven by racial hierarchy. And in the US, of course, white supremacy is so profoundly and thoroughly embedded in our structures. In fact, it's like so thoroughly embedded, we often think it's invisible. And I would say, just especially as a physician, one of the things that's coming to mind for me and for your question is there's been a lot of work recently, over the most recent, I would say 3 to 4 years, around how we use clinical algorithms and racism in clinical algorithms. And I know some of your colleagues, Delan, Devakumar, and several others have been working on this. It's just one of the many examples of normalizing the white body as the gold standard and as the standard of health. And that may seem unrelated to your question around like how inequality develops, but it's in the US context, it is such a profound part of the system. And so it's such a profound part that it shapes how we practice medicine and shapes how we how we understand normal and the gold standard. And the normal gold standard, healthy standard is the white body. And that leads to us, of course, prioritizing care for white people, ensuring that access to specialty care is predominantly for white people. The levels at which it impacts everything from access to just the culture of medicine to the way that health providers take care of patients. It's profound, and it's really a symptom of an ideology that shapes inequality, right? And that ideology is white supremacy. And doctors often don't, and I'm always critiquing doctors since I'm a doctor, but doctors often don't even recognize how much that ideology is shaping the way we practice medicine. So much so that, data show that Black neonates, Black, newborns are systematically 3 times more likely to die, to lose their life if they have a white neonatologist as opposed to a Black one, right? So it's profound. So I mean, that is a huge part of what ideology structures inequality in the US context, for sure.
I definitely want to come back to this point about racialized vulnerability with regards to the pandemic, but I'm going to go to Barbara and then Anne first. So Barbara, if you want to unmute yourself.
As Michelle was saying, of course, there are many different facets to this question. I think two of them that come to mind for me are the first one is that when you have great inequalities, then you also have typically very, very bad poverty. So you have people who don't only have fantastic, high quality top healthcare, but they have very bad access to healthcare. So they're starting at the worst state. They go into such a thing as a pandemic with worse health conditions, more pre-existing conditions, more vulnerabilities, and now I'm now coming to the second point, less trust. And everyone was now, everyone, I shouldn't say everyone, that's too sweeping, but we have a study with 23 countries where we talk to people of how they get through the crisis. And in all of those countries, the government rhetoric is that we have to convince people to follow the rules. In many of those countries, a significant part of the population has had very bad experiences with public authorities, with state institutions. I mean, the textbook case is vaccinations, right? People are hesitant to get a vaccination, not only because they don't trust Moderna or they don't trust a particular way of creating a vaccine, but they don't trust the authority that wants you to get vaccinated, because this authority has approached you with distrust and has discriminated you and done more horrible things. So I think in countries where inequalities are higher, where there's a significant part of the population that lives in poverty that's being discriminated against, you will have overall worse outcomes, and you will get through the pandemic, through any crisis actually, in a worse way than in countries with lower levels of inequality.
Can I just jump in with a question before we move on to Anne and Carlo, which is, when it was first hitting the news that there were these huge inequalities in terms of coronavirus infection rates and death rates for communities of color in Britain, right? So certain communities of color were between 2 and 4 times more likely to die from coronavirus. Two kinds of explanation was initially offered. One was, and this was unsurprisingly from, kind of right-wing pundits, a very lazy biological essentialism, which is, well, these people have different skin colors, genetically they must be different. And also drawing on the fact that you already have these pre-existing unequal healthcare outcomes and kind of making them a kind of aspect of racial biological essentialism, right? That I am just naturally more likely to get diabetes, therefore naturally I'm going to be more vulnerable to coronavirus. And then the second was cultural explanations, right? So locating differences in environment as a kind of expression of cultural difference. And what both those things did was kind of essentialize inequalities and how those inequalities manifest. So just really quickly, right, because I don't want to presume too much familiarity on the audience, right? Can you tell me why those explanations are inadequate or don't grapple with the nature of inequality in healthcare outcomes? Why is it just not my genes, is what I'm asking.
Is that for Barbara? Or, I mean, I think...
Anybody who wants to answer that question of just so my mum doesn't feel too blamed for giving me the bad genes, please rescue her.
Yeah, I mean, I actually think that these are deeply linked. I mean, so this ideology of responsibilization, of this idea that if only you wash your hands, and if only you stay home, and if only you do these things, then the society as a whole will be safe. That kind of responsibilization is actually deeply connected to a refusal to see racialized exclusions. And so, I mean, I think even the idea of stay at home that assumes that intergenerational risk will be prevented by staying home, I mean, you could see that as cultural, right? The tendency to live in multi-generational homes might be cultural, but it might also be economic, right? So who can afford to live alone in London or in single generational or nuclear family homes in a place like London? I mean, I think that those things are absolutely interconnected. And for me, one of the really clearest voices on this has been Ruha Benjamin. I don't know if folks here are familiar with her work, and she's done some videos about this. And her book, Race After Technology, is a really good resource for a lot of these kinds of questions, but around the algorithmic inequality that Michelle mentioned. But I think that the example that she uses is an evocative one, where she talks about early in the pandemic, there was this discussion of, masks, everyone should wear masks and just make one yourself. And she talks about a particular kind of exchange that happened on Twitter, where a Black male activist talked about how he wouldn't be safe walking into a store in anything that was a mask that was not obviously a medical mask. And that refusal to see the ways in which safety is not equally accessible to everyone, I think is part of the ideological commitment to responsibilization as a solution, rather than the kind of the changes that would be required to foster equal access to safety for everyone. So leaving aside even the fact that essential workers can't stay home, leaving aside, all of these things, that just, there's in an embodied sense, right? Safety is not equally accessible, and that is profoundly racialized both in the US and in the UK, as well as in other places.
Carlo, you had a little hand signal up earlier.
Yeah, I just wanted to mention one example. So when you think about lockdowns mean different things for different people, right? You could ask the question, what does a lockdown mean for people living in a slum? It obviously means something different for people living in middle class or upper class neighborhoods. So if you do a lockdown in a slum, it basically means that you lock people into already very crowded housing conditions, and you're basically creating ideal conditions for a virus to circulate, because it's impossible for people in slums to practice any kind of physical distancing. So lockdowns entail a very distinct class politics and create the differential exposures to the disease. So in India, where I've been living for a long time, studies have shown that the first wave affected predominantly the working poor. Living in crowded conditions, the strict ban on any kind of movement exposed them to the local circulation of the virus. But meanwhile, the middle and upper classes were protected by the lockdown in their secluded worlds. But then when the second wave happened in February 2021, the impact of the disease became much more visible, because first of all, there was no lockdown. And so it now predominantly affected the middle and upper classes. So here you can see that housing is an important issue, that lockdowns impact different people in different ways, and that there is a distinct class politics built into the very idea of the lockdown and the practice of the lockdown, and that might not always be visible.
Well, this kind of takes me on to the next question, because in the UK, Sir Michael Marmot released a report, which got a fair amount of media coverage, about health outcomes and social inequality. And one of the things that he proposes, amongst other things, is that the government should put health at the heart of every policy area, from housing to the economy to welfare. And I think all of us would agree that would be a good thing. It would maximize human dignity in policy making. It would mean people got better quality housing, they could get welfare that they could live on. You maybe move towards a 4-day week, universal basic income. All those things are great. But is this a bit of technocratic wishful thinking? That if you say we change how you make policy and therefore things will be different, rather than thinking about, maybe these class dynamics that you're identifying and how lockdown affects people, that is an outgrowth of capitalism. And that there is no way through this question of health and policy without confronting the forces of capital, really. I was just wondering what you guys thought of that.
Can I answer? policy is the way to address capitalism. So we, of course, not the only answer, of course, but we really need to use policymaking, and policymaking is, of course, not only black letter law, but we also need black letter law and other forms of policymaking to create a society that focuses on the growth of the right things, and not just on economic growth that destroys everything else. It destroys the people, destroys the planet. But I think we should not lose our trust in policymaking. I think this was also one of the powerful messages of Carlo's first statement, that we have gotten lost. We have sort of lost in the process of the last couple of years and new public management, the idea that the state can be, as a representative of the people, not only an engine of innovation, as Mariana Mazzucato argues, but also not technological innovation only, but also social innovation. And social innovation, or care innovation, that includes care for the environment and care for the planet. And ultimately, this change in policy needs to, of course, be accompanied by possibilities that will not only be created by policy, but possibilities that enable people to change their practices. Because one of the things that makes change so difficult is that we are all stuck in our practices. It's very difficult to break through those. So, and that's part of the reasons why the current economic system is so difficult to undo. And the other reason is, of course, that it is, those practices are interconnected. If you change one thing, the world will talk back on another side, at another place. But also here, we can't do this. We can't tackle this without policymaking.
Just before we move on to Anne, I forgot to say at the start that there will be time for audience Q&A. So there should be a chat box. If you put your questions in there, we will harvest the best of them and, splice them together. And then we'll have, I promise, about 15 minutes for the panelists to respond to your questions. So just keep putting the questions in and we will get to them in about 10 minutes time. But Anne, what was it you wanted to say?
Oh, just to add to what Barbara is saying about the importance of policy, that I think that we also need to think about the importance of politics far more broadly. And really if we think about the really compelling demands in this historical moment around, for example, Black Lives Matter, right? That is a really fundamental argument about this question of whether the scope of the inclusion in the body politic includes all of its members. What is the scope of membership there? And I think that so a lot of the pandemic politics that Carlo is talking about is assuming that certain classes of bodies are disposable. And really this question about which bodies are disposable, which bodies are not, right? Which bodies do matter to the body politic, I think is one of the ones that is why the politics is not only in Westminster or Washington, is not only in governing bodies, but is also in the streets, right? So that protest movements are really important in making that fundamental argument about everyone having a right to health, and everyone should be, it shouldn't be just certain sectors of the society that are constantly privileged and the ongoing inequalities taken for granted.
Yeah, I just wanted to add one more thought to that, because I just think it's, again, it's really helpful that you called out the report from Sir Michael Marmot and really appreciate, again, also the underlining of the importance of policy. But policy is so central. And I was recently learning about the Sewell report that was put out in the UK recently. So
we do not claim that report. That was Tony Sewell's business.
It was a great example of the power of policy, right? When a document like that is put out and normalized and gets the press that it gets, and is essentially erasing structural racism or questioning the existence of it, you get the kind of white supremacist policies that we are all suffering from. And I just think it's a really important, obviously, way of setting norms, but to your point about capitalism as well, and we often also talk about racial capitalism. It is so embedded, to Barbara's point, that every change of the system feels so disruptive or feels like someone's losing something, and there's such profound resistance to it. But again, ultimately, I think what the Black Lives Matter movement, to your point, Anne, and what other social movements I think help us to see is not just critical consciousness at scale, but also like that change is right around the corner if we make it so, because these are human created systems, human created policies. Racial capitalism is also a human creation. And so I just think it's important to like both mention the Sewell report, because it's perhaps the antithesis of Sir Michael Marmot's report, but also it's, especially again, being a Black woman in America and hearing about that, I can't imagine what it would be like to be a person of color in the UK with that report coming out at this particular moment in history. So I just want to make sure that doesn't get lost.
And I think this question about policy and confrontations with capital, it kind of loops back to what Carlo was saying in his opening statement about, to my mind, the neoliberal state hollowing out its own capacity to do things. So one example that I would raise with this is vaccine apartheid and intellectual property rights, where you have this very clear obstacle, which is right in the way of the global South accessing the vaccine it needs. And this conversation, when it was in the news in the UK, was happening right when you had that dreadful spike in fatalities in India. And when you've got the spike in fatalities in India, you've got, multiple NGOs saying we need the patents to be waived on these vaccines so they can be manufactured elsewhere. You've then got Bill Gates, like the high prince of capital himself, wafting around TV news studios telling us why we have to have these IP protections in place, right when people are dying. So here we've got the things that we've been discussing, which is the disposability of certain bodies, impoverished bodies, brown bodies, racialized bodies. And then you've got the need to confront capital and use the heft of the state essentially to break them back of capital's demands. So I guess what I'm saying here is that, is this merely a policy question, or is this a politics and movements and parties question? I don't know who would like to come in on this, or how do you smash through that obstacle, maybe?
I think it's both.
Mm-hmm.
So I think that the emphasis on politics and on social movement and practices of protest is really important. How do we smash through it? We need pressure from the people, from the sovereign, and we need people who have visions of how it could be otherwise. And I think we can only create the otherwise when we think all of those fields of practice and policies in conjunction. And I think some of the notions that are circulating at the moment, such as a revolution of care, where care is not only care work in the more narrow sense of the word, but it's caring, as I said earlier, caring for the planet, caring for the environment, caring for communities and people, where we have new frames within which we think, and also new metrics where we can measure whether the right things grow. These need to be developed in parallel, but we definitely need we need pressure from the people. And I think it's not going to, I will be very honest, I think it's, we just wrote a book about how we thought it should happen. But when I talk about this book, it's called The Pandemic Within: Policymaking for a Better World. When I talk about this book, then when I get asked, do you think this will happen? I'm not sure. It doesn't prevent me from trying, but we see already in the rich parts of the world how people fall back into their old practices, and not because they don't care, but because the old demands are caving in on you, right? And you just try to get through the day again. And a lot of people do not have the space, energy, power, or they feel they don't have the power to really change anything. I hope we will, though, because I think COVID has certainly shown that some things that we believed were true and some things that we believed were not changeable were very changeable. and very untrue.
I mean, maybe on this question specifically about rebuilding the capacity of the state to do things. So returning government to the questions of governance, dealing with the fact that the public sector has been largely, balkanized, bits of it privatized and sold off, bits of it subject to market logics, bits of it sort of farmed out to, quangos and sort of not being directly controlled by, the people we elected to run them. So how do you return some semblance of, I guess, command and control to state apparatus again? I don't know if you'd like to come in on that. Yeah.
I think that one piece of this, so I've written about this with regard to the Flint water crisis, for example. So where this is a really key element so as many people know, there was a situation in Flint, Michigan, where the water source for the municipal water was changed from a source that had been used a long time to a new one. And the water degraded the pipes, and so therefore leached toxins to the people. And one element of it that I find really kind of perverse, but also revealing, is that as soon as the water source was switched, the General Motors engine plant, which was nearby, noticed that the new water was corrosive because it had an engine plant and it was damaging the machinery, and sought special dispensation from the government of Michigan, which was ruling the city under emergency financial management, to get the water source changed for the General Motors water plant, or for the General Motors engine plant, right? And so, and was successful in doing so. And so to me, this is such a compelling example of, if the kind of corporate citizenship that Bill Gates is advocating worked, General Motors would have said, oh, this water is toxic. It's damaging our engine plant. It's probably also damaging the people who live in the community that we live in. But of course, that's not their tack, right? And so their tack is instead to say, okay, we want to opt out of this toxic environment that the community in which we are working has. And I think the only way to change that in terms of policy is to make it harder for companies to extract themselves from the communities in which they work, right? So, there should have been a red flag when General Motors said, we see that the water is toxic, that should have been able to be actioned by the people of Flint. And I think that we see these kinds of things happen again and again. And, and this, I think, is a much larger policy question that probably has to happen also at levels of global governance. As well as in the really local things of, that there was an emergency financial manager who was empowered to make decisions against the will of the people in a way that's very similar to structural adjustment policies in other countries happening there. So I think that there's a multifaceted way, but that in some ways what we need is greater ties to capital in the sense of making capital accountable to a democratic public. Rather than kind of trying to protect democracy from capital, because we are ultimately all living here together.
Carlo, if you'd like to come in on this.
Yeah, sure. So I wanted also to comment on your question on vaccine nationalism and questions around equity. And very often as a scholar, my function is to complicate things. And India is a very good case where you can see that the politics of vaccination is actually quite complex, and it's really sometimes very unpredictable and surprising. So one thing that people very often assume is that only rich countries are conducting vaccine nationalism or are engaging in vaccine nationalism, and then countries like India are the victims of it. But that's not really true, because India is the largest vaccine producer. So, that's kind of interesting, right? It's the world's largest producer of vaccine. And so you really need to understand what has happened in terms of the vaccine production and distribution in India. And that's quite interesting. So what happened is that India's vaccine nationalism played out in very distinct
I think Carlo might have frozen there. Tell you what, I will move us on to some audience Q&A, and then when we get Carlo back, I assume he's not just frozen for me, he can pick up his point about India vaccine nationalism and this stuff to do with production and distribution. But here's a question from Richard Gibson. Mirroring Dr. Morse's point about how whiteness is conceptualized as the pinnacle of health, could the panelists speak to how disabled people have been sacrificed during the pandemic because they are supposedly innately vulnerable as their embodiments diverge from those of us who are supposedly normal and therefore healthy? So yeah, if somebody could sort of speak to this issue around disability and almost the kind of inherent exclusion from life that being classified as disabled incurs. Michelle, I don't know if you'd like to.
I'm happy to just share some initial thoughts. I'm sure Barbara and Anne will have some additional ones as well. But again, especially as a physician, it's something that ableism is just very profoundly embedded, I would say, in the training that you get as a physician in the US, and it's not called out for what it is. And yet I am also seeing a lot of medical schools starting to integrate disability justice into their curricula in a way that's somewhat encouraging. I think the way we saw this play out last year in particular was there were these kind of crisis management of care standards that were put out by many cities and states that essentially kind of defined, if we get into a scenario where we're down to our last ventilator and we have to choose between patients, how would we decide on how to allocate that resource? You know, the age-old ethical dilemma. Unfortunately, many of the crisis standards of care that were put out there were quite ableist and quite discriminatory against people with disabilities. And so I would say watching that play out, hoping that we don't end up in that situation again, of course, where we are down to our last, oxygen tank or down to our last ventilator, but also knowing that that is playing out around the world right now, in the global South in particular, and recognizing that unfortunately a disability justice framework is not often how those scarce resources are allocated. And then of course, we have to think about this from an intersectional framework as well, and recognize that people of color who are disabled, of course, are even more likely to be discriminated against, and women who are disabled are even more likely to be discriminated against. So I think it's a really important demonstration of intersectionality. It's also a really important demonstration of how embedded ableism is, and yet I remain always optimistic that these are human-made curricula again, and therefore subject to change. But really appreciate that question. It's a really important one.
Does anyone else want to come in on the topic of disability and discrimination? Because if no one has a burning desire to add to Michelle, then maybe I'd invite Carlo to just finish that point about India and vaccine distribution.
I'm not sure when the interruption happened, so I just kept talking.
Oh no, I can't recall the exact place.
Anyway, I was just saying, like, it's interesting to see across the world. So some of the things that you can observe are counterintuitive. For instance, Morocco and Turkey are much further advanced in terms of vaccination than Japan and Australia, which is something you wouldn't expect. So that the picture is quite complex, and I think we need very detailed studies that will tell us more about what happened where and why and what were the factors, and give us better insight in terms of different types of vaccine nationalism that happen not just in the north but also in the south.
Well, we've got a question from an audience member kind of directed at you, Carlo, but I think everyone can come in on this, which is readdressing this question of preparedness. So in your opening comments, you said that the problem wasn't a lack of preparedness, but the kind of preparedness. And Penelope Quinton asks, could you please say more about this? When did this question of preparedness arise? Was it with the World Bank's call for countries to offload state health infrastructure? And how was this enforced? So yeah, historicizing, I think, maybe this question of the wrong kind of preparedness, because I think everyone's work here can touch on that in some way. So Carlo, if you'd like to start, and then we can go.
Well, it has an American, kind of origin, if you want. It emerged in the US after 9/11, mainly in relationship to terrorism and to bioterrorism preparedness, especially after the anthrax attacks. But then around this time, there was also the avian influenza virus, which was circulating, and people got very scared about it, saying it might cause a pandemic. In the end, it never did cause a pandemic. But in that context, a lot of effort and thinking went into preparing, the country for a catastrophic pandemic. But the way in which this happened very often was that, for instance, hospitals were asked to come up with preparedness plans, right, to think about what they would do in the case of a pandemic, but they were not given any additional resources in order to respond. So they mainly had to change their practices, come up with different ideas of how to admit people and how to discharge them. But they were not given more beds, or they were not actually, the number of hospitals in the US, in New York City, for instance, reduced over the past 20 years. So that was the kind of logic of preparedness, right? On the one hand, you reduce the actual capacities because you think they're too expensive. But then you're asking the reduced institutions with less people working to prepare for a catastrophic pandemic. So in that sense, breakdown was always already expected. It's not, it's not something that people wanted to prevent. They just, the idea was to mitigate the catastrophic consequences. So that was what preparedness was mainly about. And I think we've seen why this kind of preparedness is not very, it's not the kind of preparedness that we need.
Does anyone else want to comment on this question of like the wrong kind of preparedness?
Yeah, I would just like to add that I think it's interesting that Carlo mentions the 2001 anthrax attacks in the US. I'm very interested in the way that the postal workers who died, who are Black postal workers who died in the anthrax attacks, could have been an opportunity to see what preparedness would have looked like. So one of the postal workers made a 911 call, which was recorded, and I remember still listening to it on the radio in 2001, and he described his efforts to both get answers from his governmental employers and to get care from his physician. So both of these were thwarted, and he would die just hours after this recording. And so if we were to listen to him about what would need to be needed to prepare, it would have been doctors would need to believe Black men when they come in and say, I work at this postal service and I believe that I've been exposed to anthrax. And then, so there would need to be a believable, there would need to be to speak to that trust issue that Barbara made, right? There would need to be justifiable trust in the healthcare system, because when people went to seek care, even if they were Black men who maybe sounded paranoid to the doctor, needed to be taken seriously and treated. And then government employers would also need to tell the truth. And of course, those are not the lessons we've learned. Instead, what we've learned is, okay, we need this technocratic kind of preparedness models of a bunch of guys who all went to school together talking about, how their different models and their different plans and how their buddy has got a deal, right? And that is what preparedness means, rather than take seriously people who need healthcare and tell the truth.
Algorithmic masturbation
is the hip term. Is that what the kids are calling it these days?
We're calling it algorithmic masturbation because there's certainly a culture here in the UK, particularly after Johnson's government came in. He brings in Dominic Cummings, who says, well, wouldn't it be great if we just make the government more like Silicon Valley? Because, everyone has that idea. They look at businesses and they go, we should run the civil service just like this. And there was a whole lot of algorithmic masturbation of bringing in all these super forecasters who so far haven't been able to call a single thing right. But yeah, Barbara, I was wondering if you wanted to cover this question, either of algorithmic masturbation or kind of wrong kind of preparedness, the way in which there is a kind of structural weakness in how people conceived of pandemic management even before it happened.
I think the notion of preparedness of course, always has an image of what it is to be prepared for in mind, right? And there's always a tacit assumption of whose responsibility is to also fund the preparedness and be responsible to it. I mean, as Carlo has already pointed out, what has happened because of efficiency paradigms and very narrow understandings of efficiency was that those things, the preparedness that would have made a lot of people safe, and I don't mean only preparedness in terms of personal protective equipment, but in a wider sense, was considered an irrational idea because it wasn't effective, it wasn't cost effective according to the parameters that we use to measure cost effectiveness. So the conclusion should be, I think, that the way that we were measuring this was wrong. And again, here, partly there was an attempt to then devolve the preparedness work to individual households and families, right? And I'm not suggesting, and so I don't want to be misunderstood to say that, you know, the state should take care of everything and the state is fantastic. I'm very well aware that in many parts of the world this is not true. But when I say that we have to have good policy making, we have to have the state as a representative of, to act as a representative of the people and not to make these kind of narrow efficiency decisions, and that implies a change of rule, a change of who's in who has the decision-making power, and a change of the rulers in many cases. But that won't happen without people in the streets, you know, metaphorically and literally, calling for such a change of rule. But it also won't work without a vision that holds it all together from top down. So I think we really need both.
So we've only got a couple of minutes left, and Barbara, I know that you've got to run off. So I thought maybe for our last question, it would be just sort of, you know, something which is both, again, very broad, so you can answer it however you want. And Barbara, you can go first, which is, do you think that this pandemic and the way in which it has, in ways we've discussed, hit people who are already vulnerable, who are, you know, working poor, who are part of communities of color, who are disabled? Do you think that this pandemic has changed the way we think of the state's duty of care to those people? And Barbara, I'd let you go first.
Okay, I've spoken a lot, so I will be very brief. I think the way that that political and economic elites think about the responsibility of states vis-a-vis vulnerable people has not changed. I'm sorry to say. Overall, no. The way that a lot of, well, I shouldn't say a lot because I don't have data on a lot of
See, this
the world's
is the difference between a journalist and a scientist. We've got no problem just saying, yeah, sure.
In our data, we let's leave it at that. In our data, which is from Central Europe, is from Europe and partly also Latin America, we do see that people do care a great deal about how those who are more vulnerable than they and those who have less than they care a great deal about those people. And it's not the end of solidarity now. But I'm less sanguine and less optimistic when it comes to will political and economic elites put their money where their mouth is now.
Well, Barbara, I will let you go. Thank you so much for joining us. It's not that Barbara doesn't like us, it's that she's got a lovely birthday dinner to attend. And so I can possibly keep her any longer from that. But Anne, Michelle and Carlo, maybe you'd like to respond to this question. Perhaps not so much has the sense of duty of care changed, but how should it change?
I'll also be brief, and recognizing the next meeting right behind this, and also really appreciate that as a closing question. I think it's a really important and profound one. How should it change? I mean, I think again, I would go back to what I've been alluding to with, I think, all of my comments thus far, which is the disproportionate power that doctors in medicine have compared to other health professions, and why that exists, why that hierarchy exists, and how embedded white supremacy is in the practice of medicine and in the disproportionate power that doctors have. So I guess for me, especially again, since I'm a physician, I feel like I can speak most directly to reforms needed within the profession of medicine. That would be the reform I would love to see. It's not that medicine needs to be deprofessionalized per se, but we certainly need to be much more transparent in acknowledging the ways that we've been miseducated as physicians in particular, and the amount of unfair power we've had in the system in a way that has led to exclusion and led to marginalization and led to inequitable outcomes. So that's a relatively narrow comment, but I think health and well-being would be better if there was a more flat structure within how health workers operate.
Thank you so much for that, Barbara. Oh, sorry, not Barbara. Oh, Michelle, my brain. So you can tell that after that 1 hour of talking, it's like. So Anne or Carlo, if you'd like to come in, how should the sense of duty of care change?
Yeah, I mean, I don't think that it has enough. I mean, I absolutely agree with Barbara that this is very much an unfinished business and that there are a lot of elites who are not paying attention. But I would say that I think that there are young people, especially, who have noticed that a society that cares best for its most marginalized actually works better for everyone. So I think that, you know, students with disabilities have been really, the understanding of the experience of students with disabilities has been enhanced. The ability of their classmates to understand, you know, what it's like to rely on technologies or, you know, these kinds of things. I went to a really great party that was designed by Remote Access, as this lab out of Vanderbilt that does disability-centered parties. And so they've been partying online, you know, since before the pandemic. And we have a lot that we can learn from what people with disabilities have already kind of innovated. And so I think that there is a hunger, maybe not in this generation of elites, but maybe in the next one. We're really thinking about, okay, can we learn, you know, from people who, and you know, if we really benefit the well-being of those who are more marginalized, you know, what will that do to transform and really allow a society as a whole to flourish as well?
Thank you so much for that, Anne. And Carlo, I will leave it to you to bring us home.
Sure. Well, I think it's not so important to answer the question, but I think it's important to keep asking the question and to keep the answer open. Because I think we need to be creative, we need to be imaginative, we need to keep thinking, we need to keep working. There's no final absolute answer to the question, but it's important to not lose sight of it. Because, you know, there's no final answer or absolute answer to the question of what does care mean, or you know, what is care and what isn't care, or who cares for whom and why, and what are difficulties and challenges of caring. So in that sense, the questions are more important than the answers.
In the spirit of never-ending conversations, I'm afraid it's time to bring this one to a close. I just really want to thank our panelists, Michelle and Carlo and Barbara. Look, I'm a non-expert in this field, and I think the clarity and the precision with which you all spoke was just, one, I learned a lot, and two, I will most certainly take a lot from these discussions out with me in my own field of work as well. And I hope that our audience feel the same way, that they feel that their understanding has been expanded. And more than that, these are ideas which they will keep with them even after the seminar draws to a close. So thank you so much to our panelists for giving up their time. Thank you to King's for organising this discussion. There will be more Age of Health events coming up. This is sort of drawing to a close, the first section of it, but there will be a lot more of this kind of thing to come. If there's one thing people can take from this, it is the importance of public engagement. There is no point having these ideas off in a silo or in an ivory tower where they don't connect with people. I think it's really important to popularise this stuff as much as possible. So thank you to the organisers. Thank you to the panelists. Have a good evening, everybody. Good night.
Thank you, Ash.